Edwin Muturi and Charity Muturi, both of who have participated in our programs, but who also have a wealth of experience beyond our programs in as lived experience participants in many programs. So our presentation will focus on participatory research with people with lived experience in mental health study. And as you've heard, those are the presenters. So I'll start by discussing what we are going to be presenting about. So myself, I'll take the introduction. I'll go over what we're referring to when we talk about lived experience, the value of having people with lived experience in research, as well as the law policy and law frameworks that underlie their involvement. Then Edwin will take us through the strategies to promote inclusion. He'll cover the obstacles to inclusion, how to promote meaningful and authentic engagement, as well as the principles of engagement. And Charity will cover the building collaborative partnerships. So she'll talk about the role of experts by experience, the gaps and opportunity, as well as lived experience financing and capacity building. And we'll have a slide that has links to various papers that we'll have referenced, and we'll also, and there are various documents that we'll talk about in our slides that you'll feel free to access at your own time. So I'll go into now my slides have stuck. Okay, so I'll talk about what we mean when we talk about lived experience expertise. So in various documents have defined it in different ways, but basically it's that unique in-depth knowledge and insight that one gains through their own experience. So it's not something taught, it's not something covered, it's not like a psychiatrist's knowledge of the problem from what they've studied in school. Rather, it's what somebody learns through their lived day-to-day experience with their mental health condition. And we recognize that there's diversity in each person's individual recovery journey. And each person knows better than anyone else how it affects their life, what they go through to get a diagnosis, what they go through to get treatment, how the treatment affects them, how the symptoms or side effects impact their daily life, and what it's like to interact with the healthcare system. So that wealth of experience is what we talk about when we say lived experience. So it's based on one's perspective. So it's unique in that my perspective of living with anxiety would differ from somebody else's perspective. It's different based on personal identity. So how a woman experiences the system, it would likely differ from how a man experiences it. How a youth experiences it maybe would be different from an older person. Same thing, with it a refugee, their experience would be different. So with the current capturing all these different perspectives and the perspectives of people of different personal identities, whether it's sexual, gender, age, all the kinds of different identities, their experience would be likely different and unique. And also the history. I mean, if I have access to care, my experience will be different from somebody who doesn't have access to care. If my access to care is through public services, my experience may be different from somebody's whose access to care is through private. So all that, these are different perspectives that people with lived experience bring on board. So they contribute, we contribute in ways that no other expert in the field can offer, because it's my unique perspective, what I am going through. It's different. I could explain to you how to walk in my shoes, but you cannot say you truly understand it unless you hear it from myself. So then I'd like to mention that it includes an experience of different mental health conditions, and different people interact differently with their mental health conditions, the strategies that have been put in place to address these conditions affect people differently. And sometimes we hear people use the term lived experience when they're also talking to caregivers or the family members. And we respect that, because living with somebody with a mental health condition, you too have your own experience to share. So it may not be the experience of living with the condition, but it can be an experience of caring for somebody. So they also know how they interact with the system, what they observe, and their view is also very well valid. So there are different terms used to describe the people with lived experience. Some use the terms lived expertise, living experience, patient expert. So what we would request you researchers, maybe not service users. At times we hear the term service users used, but that limits the experience of somebody to only the interaction with a service provider. But the interactions are various, and at times even the person themselves who has a lived experience can be a service provider, like maybe Edwin will take time to explain about his ADHD coaching. So maybe not to use the term service user, unless of course when referring to services. So I'll move on to talk briefly about the lived experience value. And one thing that engaging people with lived experience helps us to do is to move from this one-size-fits-all interventions. When you have a diversity of views, you talk to people who have experienced the private system, you talk to somebody who's experienced the public system, somebody who's experienced maybe the care from other non-conventional care. It can help us inform the development of either policy or practices that really reflect the choice and the will of somebody who themselves has a condition. So it's important to listen to their voice, because we have in-depth experience of the social and human rights impacts of living with a mental health condition. It's about that hardship, and I have experienced the hardship of being ostracized, marginalized, discriminated against while struggling to navigate that mental health system to seek services. The kind of perspective I bring can really shape what kind of services can truly promote my recovery. It would be excellent if research really takes that on board and informing policy and practice. So we say it's important because they provide an understanding of what is needed also to remove the barriers to inclusion. When I talk about high experience stigma, then it makes it easier for people who, for example, in our campaigns, when we talk on media, and we basically, I don't want to be portrayed as a victim all the time, or I want my story of recovery told, not only my symptoms, and to be seen more as a person. We have people who say I'm a mother, I'm a wife. So don't just portray me as somebody, a depressed person. That's not my identity. So when we listen to these voices, then we know the kind of narratives to tell, how to speak about it, and I'm sure the language of inclusion will be spoken more by my colleagues, Edwin and Charity. So the next thing having a voice of lived experience can do is also to catalyze political action. When you have all these people and they are given an opportunity to give their voice, we know how politics works. It's about numbers, it's about people's true experience that shapes these things, that moves of politicians to act, that moves people to legislate, that moves people to change how things have always been done. When they see the people, what they're doing, I mean, these actions, the people they are affecting, maybe it could lead to a better improvement and across sectors, so that we're not only limiting our conversations around mental health to the health sector. I mean, it's about how I experience my education. If I'm a child with ADHD in a public school, how am I experiencing education when I cannot concentrate on something for so long and I'm being beaten for moving about? If I have a panic, anxiety disorder, and I'm having a panic attack when a teacher points at me and asks me a question, am I being beaten for not responding? Am I being told I'm disrespectful? So it's across sectors where we can truly change the practice that accommodates people with mental health conditions. And I'd like to say it's important to also capture the perspectives of people in different geographical, cultural, political, economic, social contexts. They all affect the condition differently, and different, all these different spaces have things that they can do to contribute to a better experience for somebody with a mental health condition, and we can push for more accountability and governance nationally and regionally. And of course, people with lived experience are uniquely positioned to provide suggestions for cost-effective and practical solutions to enhance mental health system and even the referral systems. So I'd like to briefly also talk about some policies that underlie recognizing the lived experience value. So the first one I'll mention is, and I'd like to say there are many, but I'll only briefly talk about three, but there are many frameworks. So the first one I'll talk about is the UNCRPD. There are also many, the WHO Mental Health Action Plan, the WHO Quality Rights Initiative, the WHO Guidance on Community Mental Health Services, Lancet Commission on Ending Stigma and Discrimination in Mental Health. All these talk about the value of engaging people with lived experience. So in the UN CRPD, a key principle of human rights-based approach is people's right to participate in decisions that affect their lives. I think that's pretty straightforward. If it affects me, I need to have a say in it. So we insist people with lived experience need to be meaningfully engaged in research and in various other sectors. It also calls for full participation and meaningful engagement of people with mental health conditions, and I'll briefly talk in a bit talk about that meaningful engagement. So we say people with psychosocial disabilities. When we talk about the UNCRPD, of course, we're talking about the rights of persons with disabilities. For some people, they struggle to see mental health conditions as a disability, but many do recognize that there are psychosocial disabilities. And this involves actual or perceived impairment due to the diversity of emotional or cognitive experiences. So while there are a lot of information and a lot of devices for people with physical disabilities, there is room to see what kind of devices or technologies can assist somebody with a psychosocial disability. So, for example, is it noise blocking earphones? Could I get a subsidy if I need noise blocking earphones for my schizophrenia? If it helps me not hear voices, can that be? Can I get access to that even if I don't have the resources to get it for myself? The same way somebody with a hearing impairment gets a hearing aid. So there are researches that can be done. There's a few that have been done on assistive devices, and maybe there could be some done for our context, or what kind of devices could help people with psychosocial disabilities. Then when it comes to the public stigma that relates to mental health conditions, there are these negative stereotypes that sometimes could prevent people from engaging even in these researches. So somebody, maybe a lot of people assume that somebody, yes, they would want to involve somebody with a lived experience, but they question whether they have the insight, whether they are capable of meaningfully engaging. And I want to insist, yes, we are capable of meaningfully engaging because symptoms tend to be temporary and they are treatable. So the fact that I have schizophrenia doesn't mean I'm absolutely unable to, maybe not when I'm having my symptoms, but again, my colleagues will cover that. But we need to recognize that people do have the ability and the capacity to meaningfully engage as the UNCRPD calls for. Of course, people will avoid engaging where situations will expose them to more discrimination. So we need also to be careful in how we engage, not to disempower those we engage. There's also the United Nations, the SDGs.
Sorry, Rosemary, I think we are losing you.
They emphasize the need for inclusive mental health policies and services that recognize the perspective.
Hi, Rosemary. I think we lost your presentation. Let's give her some moment to connect again. I think she's having some problem.
Hello.
Yes, now we can. Sorry, we can still hear you, Charity. I mean, Rosemary. Welcome, Charity. I think we lost Rosemary for a moment.
I'll request
Yes,
Edwin. I think the network is.
yes,
Yes,
welcome back,
sorry.
Rosemary. Now we can hear you. Sorry, we lost you at some point.
Maybe if you could let me know how far back did I drop off? Had I talked about the SDGs?
It's the SDGs.
Okay. I was just about to conclude my bit of introduction. So I had just mentioned about the SDGs, and they too call for the engagement of the perspectives of people with lived experience. And finally, I wanted to share something. I'll quote it from the framework, WHO framework for meaningful engagement of people with non-communicable diseases and mental health and neurological conditions. And it talks of meaningful engagement as respectful, dignified, and equitable inclusion of individuals with lived experience. And it mentions that this should be done across a range of processes, activities, within an enabling environment where power is transferred to people. And it also refers to valuing lived experience as a form of expertise and applying it to improve health outcomes. My colleagues will talk more about this. And related terms to meaningful engagement is participatory approach, such as what we are discussing, patient involvement and engagement, person-centeredness, among other statements. So I'll welcome Edwin at this point to proceed, and he'll share practically what does this look like. Thank you very much. And apologies for the hiccups with the technology. We would request to hold questions until the end, if that is all right. Thank you.
Thank you, Rosemary. I hope everyone can hear me well.
Yes, Edwin, I can hear you. Thank you.
Yeah, let me share my screen. Can everybody see my screen?
Yes.
Yes, yes. Please make it on presentation mode.
Yeah, presentation mode. So I'll cover, my name is Edwin, and I work for Global Mental Health Peer Network in South Africa, but I'm based in Kenya. So I will cover part 2, that is strategy to promote inclusion. And I will start with obstacles to inclusion. We have to be cognizant that when it comes to research and many mental health activities, you'll find that people with lived experience are not included as is supposed to be. So these are some of the barriers or obstacles to that inclusion. And like you can see on my screen, stigma and discrimination, devaluing personal and collective experience. And I think one of the major challenges that we have generally in mental health is stigma, because stigma decreases access to care. Stigma is one of those big issues that prevents anything that has to do with mental health to move forward. And research is no different. And there is this misperception of people with lived experience being able to contribute to research because they have a mental health condition. And that is something that is constantly happening. And even if you find people with lived experience, most of the times it's just to tick a box so that it can be seen that this research did include A, B, C, and D people with lived experience. And there's also that perception that people with lived experience cannot be able to make decisions. Therefore, they cannot be able to participate in decision-making processes. They cannot even be able to participate in decision-making that directly affects them. So those are some of the things that now bring out now the stigma, the discrimination, and devaluing that my lived experience can be used to change or make things better, or let people view some of the things that need changing to be viewed differently. And there is obviously paternalism and power imbalances, and that is a major issue. Then the next bit is how to involve people with lived experience meaningfully and authentically. Get. So here we are looking at we need to understand that people with lived experience, whenever they are going to be involved in research, they should be part of the research process, and they should be included at all levels. So if you have to include people with lived experience, and for it to be meaningful and authentic, it has to be people with lived experience have to be included at all levels, and they have to be made, and you have to provide information so that they can be able to make decisions and give feedback at every level of the research process that they are engaged in. And there's this also issue of lived experience is not a qualification. And this is where it gets very interesting, because we have to understand, and now this I'll borrow from my own personal experience of a few of my mental health conditions. I mean, nobody can understand bipolar the way I understand it, because even if you went to school for it, you don't have bipolar. So you don't have the experience of the highs and lows, and the challenges and all that comes with having a condition like bipolar. So the fact that it is not something that I can go and receive a certificate, a certificate in a university or in a college or in a learning institution, doesn't make my experience less of an experience than any other experience. So these are some of the things. And how do you involve people with lived experience? You also have to be cognizant of the impact on their mental health and well-being. So there is that challenge, because at times people do not want to provide maybe the necessary accommodations that might make my work with a research team or some research work much easier and much fruitful in the long run. And at the last bit is we neglect to adequately budget for lived experience inclusion, devaluing monetary value of lived experience. And I know this happens a lot. The assumption that I will go and share my experiences and I'm just doing it for the good of the community, And like in the African setting, most people will even say, God has put you through this, so it's a blessing in disguise, so just share with people. And at that time, you're not factoring in that maybe I used my fuel to drive to your location. I used data to have such a meeting, and the essence of that lived experience bit that part, because you cannot get it from a psychiatrist who doesn't have a lived experience. Even if you paint it, even if you do what, you cannot get it. It has to be from someone with that specific lived experience. So the assumption that I'm doing it out of the kindness of my own heart, and it's going to be used in so many big platforms, but in those platforms, you'll find that people have been engaged and they are being compensated fairly. So not considering that cost also to the organization or to the person, the resources that I would need to participate. That means my data, my electricity bill, my fuel, you name it. And not considering the value of expertise and contribution to project outcomes. For example, you're having a research on ADHD, and you need people with ADHD, and you bring me in, but you are not going to consider, or you're not going to put value, any kind of value towards my contribution towards the end outcome of what you're doing. And that is something that is basically very dehumanizing and also very stigmatizing. And we are actually looking at it from, when you look at that issue to do with budget and valuing and monetary value, we are looking at it from, equal pay for equal work. So it's very important that we recognize and we appreciate that. And for example, for the organization I'm currently working on, we are working on a model that will have like a way to value and to place people with lived experience and how to pay and rate them, just like any other regular consultant that you would have in any team, because that now will start bringing that issue of my experience and my contributions as equally as important as any other person in the team. So what is the roles of experts by experience, or EBEs as we call them? You will find that this is just a highlight. We can go deeper, but I know we don't have really the time, but you will find experts in experience or experts by experience, or with lived experience, so to speak, in providing their experience in international agencies, donor funding organizations. You will find that in the corporate sector. You will find that in academic research. I personally have been involved in research with the university, the King's College of London. I have contributed to the nonprofit sector, to some government sectors. I have used my lived experience in corporate settings to talk about mental health and have and I remember there's a research I was involved in with the Wellcome Trust about 2021, and it was looking at the workplace issue and workplace mental health and stigma, and how it affects people with lived experiences and in a workplace. So I was brought on board as a person who has a lived experience and who has experienced workplace stigma, and who is willing to engage with people to understand what happens in the workplace. So that was my contribution, and it was they remunerated. And the interesting thing with these, because that was some of my initial engagements in terms of research, I was involved from the onset, when they were designing the questions, when they were every bit of it, I was involved. There is nothing that I didn't we didn't cover. I was involved from the process, and that is what we were saying: meaningful engagement, not to just bring them on where you want to hear their story and then it's done. They don't know what happens after that. So inclusion in research. Now, this is what I was previously referring to, like you are included from the start, like development of research questions. Personally, I've been involved in a few projects that I was part of developing research questions. And I was also involved in the planning and development of everything in terms of data collection, in terms of dissemination, in terms of data analysis and interpretation, the whole process. And I have been, I think I have been part of a few of them that have included me right from the start and to the end. And that has actually also made me, as a person with lived experience, actually value my lived experience. I just don't give it out because it's not something just so free to give out. It's not out there. It's not so easy, and I think being in a position where I have been taken through recognizing the value of my lived experience is also part of why I'm here, to let people know that lived experience in research has value. It should be valued. It should have, everybody, the people with lived experience should feel as included as just any other person in that particular research. So how do you promote meaningful and authentic engagement? Inclusion from the start. It's and this is something I think I have just mentioned, and it's right from the start up to the last bit, even the M&E, monitoring and evaluation phases. And you will find that because initially, and this is what we are trying to change, initially, because people think that as a person with lived experience, I don't really have any value per se. You will find that people will not, or the research team might not include me in such processes. But one thing that we're also trying to communicate in promoting meaningful and authentic engagement in diverse fields is, one, the person with lived experience. Lived experience is just part and parcel of who that person is. So you might choose not to include me because I have a mental health condition, but maybe my professional background is maybe monitoring and evaluation. You just look at the fact that somebody has a mental health condition and you don't include them. So include them from the start, include us, so to speak, from the start. And the other bit is information and communication should be provided in advance. You are dealing with people with lived experience. You're dealing with people who have, who are dealing with quite a bit in terms of managing their mental health, conditions. So make sure that information is provided on time. Make sure that the information is clear. Make sure that any questions that are raised from the information that you provide, that it is promptly responded to, because you might not respond, and you think that maybe the person that has asked you, or the people who have requested for that information, maybe are struggling with anxiety, and you might not have an idea of the kind of torture that person is might be going through, or that group of people will be going through, understanding why are you not responding, why have you not said anything. And I ask the question, did I make a mistake, was I wrong? And it becomes a whole cycle. So it's good that the responsibilities and expectations are well laid out, and information is properly communicated and cascaded in the right manner. There is also promoting well-being. Of course, you need my input in your project, or you need lived experience input in your project. But there is more to that input, and there is more to that than just there is more to that. because this person you are engaging, or this group of people that you're engaging with lived experience, these are people who have their lives, they have other things. So it's not that they are just there today and tomorrow for the next 6 months, just waiting for you to just, they have their own lives outside that. So it is important for you to, for the research team and for the research project in general, to understand that we need to be able to promote people's well-being. And this now brings in the issue of reasonable accommodation. Reasonable accommodations, we are looking at, you are in Kenya, your research project is in Kenya, I'm in the States. Our differences, that is one thing. We are looking at understanding that maybe my medication works very differently. So you want me to wake up at 6, but even if I sleep at 6 in the evening, I'll still not be able to wake up because of my medication. Does that mean that I cannot contribute to research? No, that means that we can have some reasonable accommodations based on, and reasonable accommodations are mostly individual based, because what I might need because I struggle with ADHD might be very different from who has bipolar. So we need to understand that, even as we include people with lived experiences. So we look at having a safe spaces for engagement when you have meetings, or when we are in the process of conducting research, and such aspects. And then we go to look at resources and support. We must have sufficient resources, logistical support, accommodation of allocation of reasonable funds to earn financial compensation for people with lived experience that align with equal pay for equal work. You get. And this is very important. It's not about just the money. It's about are you providing some of these resources? Are they sufficient, or have you just budgeted for the people you consider to be core in terms of the research, and the others is just like a miscellaneous cost? So logistical support. Here we are talking of things like meetings, time differences if you're having online meetings, language barriers and all of that. We are talking about transport if people have to move from one location to another. We are talking about getting access to hotels that might cater for people with lived experience, maybe physical disabilities or psychosocial disabilities. These are some of the things that we are looking. So it's more than just financial compensation. It's a lot of things that would affect a person with lived experience. And then when we look at principles of engagement, we are looking at power imbalances. And these principles are we are basing this on values like respect, responsibility, accountability, anti-discrimination, equality, equity, confidentiality, integrity. All these issues are very important when it comes to engaging people with lived experience in research projects, because people with lived experience are already dealing with so much. So we do need, when we are engaged in any project, whether research or any other thing, we need a space or people who actually see our value and respect us, people who actually do not discriminate Edwin because he has bipolar or because he has, attempted suicide. We need people who will look at Edwin as a person who, is responsible, a person who is managing their mental health, a human being in general, just like any other. So be upfront, have integrity when you're dealing with us, be open, be fair, and make sure that these are the things that you uphold so that we can be able to have an engagement that will impact lives as we intend to. So there are things we call, considerations or reasonable accommodations. And reasonable accommodation, I think I had mentioned these earlier, but these are specific to each individual, and it's now for the team or for people to understand that this person might require this and this person might require this, and we come to a place where we both can accommodate that person. I heard Rosemary mention about what you call noise cancelling headphones, and like personally, I actually benefit from having noise cancelling headphones, and people at times thinks actually I put them on for music, and when they hear the cost, at times they just think I'm extravagant. But in noisy environments, if I come to your office and it is noisy and I have to work, they will help me block out that noise. So imagine being in a research team, and maybe you are in the field and there's that need to concentrate. Some of these things might help. Okay, so it is important for as the project begins and as we look at everything to understand that some people might need reasonable accommodations. So we experience, very different mental health conditions, and we have side effects of medications. Like some of my side effects is I don't sleep that well. Okay, so it becomes a challenge when I wake up in the morning, or in the middle of the day, I'll feel sluggish. So if I'm involved in a project that is needing me like 24/7 or needing me on a daily basis, I prefer waking up very early in the morning because I'm good with that, and working up to around 12 or 1, because after that I will. So those are some of the things that some people might need. And when we look at reasonable accommodations, like I said, we are even looking at it in a bigger scale. If you have a research team and you're flying them out, understanding, that some people might, when you're booking flights, I know people who don't want to sit in the window seat, they want to be in the aisle seat, and that can mess up their flight if they don't get that. So these are some of the things that we might a person with lived experience might benefit from and might need when you are doing when you are dealing with a person with lived experience, when you're booking hotels. These are some of the things that so this is what we mean by reasonable accommodations. Reasonable accommodations, like for example, you can look at give reasonable deadlines and timeframes. Look at, I have mentioned about time zones, and one of the most important things that I think people might not, and I think it's people do not really look into it, is the concentration span of people. At times when you have too stretch, you'll find that some sessions just do 1.5 hours, 2 hours, 3 hours. By, like, for example, in my case, giving an example from my own lived experience, you put me in a session for 3 hours, I will be good maybe for 2 hours. The last hour, I'll be struggling. So if it is broken down, yes. If you can be able to give breaks in between, well and good, but those are some of the very simple, reasonable accommodation that a person who is not experiencing, such challenges might not understand, and providing information, from top to bottom, such that a person can look through whatever information is there and ask questions and get timely feedback. The other important thing is, do we have peer support in such settings? Yes, you are running this research, but you have people with lived experience, and you even have other people, but it can get overwhelming. Is there peer support? That is where we were talking about when it comes to promoting well-being. what are you doing for that team so that if in case they get burned out, if in case they get overwhelmed, what do you have in place? Or do you just, force them to go on, or just kick them out just because they have experienced, some challenges? So these are very important things for a person with lived experience, and a person as a person who has worked with a few, been involved in a few research projects that involve, providing, involve maybe deadlines, involve things like different time zones. I have observed that most of them have given us reasonable accommodations, especially in terms of time zones, the sessions that we are having, the information that we are providing. It is something that they have basically been able to look into and come up with a way that we can feel that we are part of the process and we are not being left behind because we have a lived experience of a mental health condition. So this last bit is basically like an acronym for what we understand when it comes to lived experience and being involved in a lived experience research. We can say it's sorry, I think just a minute. Yeah, we're looking at it's from the word consult. And one, you look at create an engaging and supportive space to enable quality contributions. Okay. The other bit is obtain diverse representation with of people with lived experience. Like if we are engaged in a research project like the Global Mental Health Peer Network, we have members from all over the world. We have representations from Africa, we have from Asia, America, South America. So at times we will be required to will be involved in a research, and they only want people from low middle income countries. So we have a pool that we can get that has people, and people with diverse conditions, because maybe the project is looking at schizophrenia only, so we cannot bring in a person with a lived experience of bipolar. But if we are talking about depression and anxiety, and they want people from both low income and high income, so we'll get a person from Europe, a person from America, a person from Africa, a person from Asia, a person from India, and you find that that is what we are calling a diverse representation of people, so that you can enhance the equality of what you're doing. So we say no to power imbalances, tokenism, discrimination, and stigmatization. And as a person who has actually experienced a lot of stigma, I think this is a big one for me. And I know most people with lived experience know how this feels when you actually face a stigma when you're involved in a project or involved in any engagement. So these are some of the things that we even as you conduct your research, this should be at the back of your mind, and sustain a mutually respected partnership. And I think this is very important because, and I'll borrow from my lived experience, when I got involved with the Wellcome Trust for the Workplace Mental Health Stigma, research project, I remember very well that after we were done, I think through what we did, I eventually got to work with two other organizations based on that, because and this was borrowed. This I borrow from the fact that it was a very good partnership. It was a very good engagement for both parties, both the Welcome Trust and the people who we were working with. So these are kind of mutually respected partnerships, and creating such will definitely put your team and people who you are working with in places where they can be able to engage more and work and provide more resources in terms of what they can contribute to research. So uphold the principles of effective engagement and consultation. And this is of utmost importance because you look at this now will remove the aspect of tokenism, the fact that you are putting Edwin, or you are bringing in Edwin in the research team because you know that if he's included, these will have some weight and this will look good for you, but you are not really engaging him. But if you uphold the principles of effective engagement and consultation, it means that Edwin and any other person with lived experience as part of your research project has been involved from the beginning to the end. And when we talk of the beginning to the end, even before the research starts, like for some of the ones I've been involved in, before it starts, we have had like an orientation meeting and we are taken through, this is what will be required of you, this is what we need, this is what we might look at, and so that even as we engage, we already have that feeling that we are part of a team. So that is very important. And then leverage lived experience expertise through meaningful and authentic inclusion. I cannot say more about that because that is basically self-explanatory. And transform policy and practice that is an accurate reflection of lived experience voices. And that basically is trying to reiterate what we have always trying to put across, that the voices of people with lived experience matter, and they for research, for policy, and for service delivery to be effective going forward, we have to have people with the lived experience talk about how they want presented, how they want each and every aspect of their life to be looked into or to be looked at. And we can only do that if we are in a position, or if we put ourselves in a position that I am here, my voice matters, and we need to work together. Can you hear me?
Yes, we can hear you now. We lost you for a second.
Okay. I was at the last point. I was talking about transform policy and practice that is an accurate reflection of lived experience voices. Simply saying that people with lived experience have they have a voice, and that voice matters, and that voice is important. It's of utmost importance that whatever people with lived experience to be taken into consideration and to be taken with the weight that it deserves. I think that was my last bit, if I'm not wrong.
Yes. Thank you, Edwin. You're correct. So we would invite Charity
Okay.
to present. Thank you.
Okay, thank you very much, Edwin. Please stop sharing so that I'm able to screen share.
Yes.
In the meantime, my name is Charity Muturi. I have lived experience with a mental health condition as well. I live with bipolar disorder specifically, And I'm very happy to be here. I think Edwin has done a good job. Rosemary has also done a very good job. And I have seen some questions that are very interesting, and I look forward to us answering them. So I'll try to go through my slide quickly. I think Edwin has covered a lot of things that I would have said, and so I will not belabor too much. But feel free to keep asking questions, and we'll address them at the end. So I would like to call myself a lived experience expert. I serve in the NCD Alliance Global Advisory Committee, that's Non-Communicable Disease Alliance, where I have been making mental health a priority. And we are glad that now both at the WHO and at the Alliance that has members in every country, mental health has been included in the top 5 NCDs together with cardiac, cancer, chronic respiratory, diabetes, hypertension, and so on. I also served in the National Task Force on Mental Health, representing persons with lived experience. Currently, a court petitioner to decriminalize suicide attempts with the Kenya National Commission on Human Rights and the Kenya Psychiatric Association. And together with Basic Needs Specific Rights, we are championing the World Health Organization Ministry of Health Quality Rights for Mental Health Training. Actually, when you're not being able to reach me, I was speaking quickly at Daystar. We've had 2 sessions at Daystar and USIU today on the Quality Rights Program. And I've also been able to influence policies in 8 national and regional as well, regional being counties. And also bringing together persons with lived experience to come up with Parliament and Senate policy submissions that are in relation to mental health. And this is, the COVID response, bill, disability, social health insurance, NCD response, the Mental Health Act, National Suicide Prevention Strategy Committee investments, and so on. Having policy submissions that benefit us at the end of the day. And we do know that we are covered by very many rights. And so being able to do public participation has been a highlight, I would say, for me. And also when COVID hit, all of a sudden our services were stopped. I'm a patient of Mathare. Clinics were closed, wards were closed, patients were called, come, your families were called, your patients are well, come and get them. And we had to really fight with the media to get it back open. And I also serve in the Nairobi Prison Wellness Committee because prisoners and security officers are at higher risk of mental illness, and being able to run simple, sustainable programs at the prison has been a pleasure. Beyond that, also writing, and I mean, even in these platforms that I have talked about, the main role has been leveraging and promoting lived experience inclusion. And that has also been in a UN NCD compendium, the Global Charter of People Living with Non-Communicable Diseases that we developed together with WHO, the meaningful engagement of people living with NCDs, which was a first publication after an informal consultation with 50 patients across the world representing NCDs, mental health and neurological conditions, as well as the framework. We were very involved from the beginning to the end. I think it was a 2-3 year process with WHO, and it's been a fulfilling journey. I think we started off with Edwin, and so I've admired his journey, and many who we started with are not with us, and so I mean we have come a long way. I think in terms of explaining why policy, it started off with, when the task force was formed, because I'd done prison programs since 2012. My training is in community health and development. And so we had, I was concerned about our constitution, for example, referring to us as imbeciles and idiots. I was concerned about people at Mathare wearing prison uniforms. I was concerned about laws that are discriminatory, where we can be, divorced or lose land or be denied leadership opportunities or employment or education on the basis of lived experience. And that was my priority. But then I had people with lived experience asking, why are we not on the table? When the doctors give these medicines, do they know how it feels to receive that injection or to adjust to it for 3 to 5 years? And so inclusion was not my agenda, but because several people called, I am a policeman, I cannot do this publicly, I am a prison officer, I am, a patient, my doctor is in the task force. Like, so many people were saying they want to talk about it, but they had barriers that I could understand. And so I decided, okay, all these things I wanted to campaign for are important, but why, since it seems I have nothing to lose, why don't I push for this inclusion? And through that, we're able to push through media using the same policies we are talking about that Rosemary has gone through, the UN Convention of the Rights of Persons with Disabilities, WHO quality rights, because in reality, the rights that we have, we benefit from the disability movement because we still do not have rights on health inclusion specifically. And so from that moment, I realized that as a member of the task force, I was able now to push for all these things. I was able to take the task force to prison and to meet with persons with lived experience and with religious leaders, because my father is a bishop and I do advocacy in churches, mosques, and temples. And so it was an opportunity to use my experience in working with 50 families at Mathare through their treatment, my experience in working in, various support groups where we've supported thousands of patients, and being able to harness that and then talk about lived experience, not only from my own lived experience with bipolar or caring for parents who also have mental and neurological conditions, but the shared experiences of all these people. And I also brought caregivers and users together, and we worked on a presentation together, and we included every invisible disability, even the ones who do not consider themselves, because you are researchers, you will get to see that there are people who are very stuck at what mental health conditions are. But we called out to, parents of children with Down syndrome, epilepsy, dementia, and we tried to get everyone on the table. And so let me just go to the next slide. My experience in research has been varied. I think sometimes I'm jealous of sorry, we call him Wawangoi, Edwin, because he had a lot of support when starting with organizations. I have had experience in doing advocacy and policy, trying to figure things out on my own, getting people who are figuring out on their own, and it's very difficult. And in terms of research, I have been involved from strategy, especially with the processes of the Global Charter, the meaningful engagement, the WHO publication. Those ones we started from the very start. Research development, I remember there's a doctor from Cambridge and Oxford who was doing access to services, essential, what do we call this? Essential medicine supplies, that's drugs and equipment. And so I was involved in bringing together people from different counties so that we could have good representation, having representation across mental health and across NCDs. In distribution, like in all of them, I've been involved in various levels, sometimes only at one level. So like distributing service, I just wrote Rikuze. For each I'd written 5, but we agreed with Rosemary that people will be busy reading through. So like the Ikuze one was on access to employment. And so we were able to just say what it means to us to be denied employment, or, even to be marginalized by persons with physical disabilities who feel like we are encroaching into their rights. But that was good because we were able to craft a message that appealed to persons with lived experience, because there were so many surveys going around after COVID, and people write very entitled things. They just send a link and say, share widely. generic messages, and you don't know what the survey is about. Is it an individual one? Is it an institutional one? How will it benefit us? And it just got to a point where so many surveys were being shared and no one was filling them. But we were able to craft a message to help them understand how this will help. And we even got back to the same people and said, thank you for your contributions. This is what we were able to do. These recommendations have gone to this institution, this institution, this is what National Council have said. This is what. So I think I liked that, because it was not only from beginning to end, but the people who are doing the research listened, and they listened to what matters to us, even in the research process. And even feedback. We rarely get feedback on surveys. And even if you say it's going to inform policy, how does that translate to me getting medication today? How does it translate to my reduced discrimination today? So these very blanket promises, don't appeal much. And sometimes if a research is facilitated, which is very rare, then people would be joining because of the financial contribution and not because they're interested in the survey. Disability, we've done very many focus groups, whether it is reproductive health systems for persons with disabilities, or how caregivers were affected, especially those who are taking care of multiple disabilities in their homes. In analysis, I am in a monitoring and ethics committee with the University College of London. And I think we have 3 to 5 committees and we don't get to talk. And sometimes I really just want to know, why was this strategized in this way? But it's the ethics systems that you have in this industry. Reporting, we engaged with a lot of criminal justice partners, especially as a task force, the National Council of Administrative Justice, Administration of Justice, the ODPP. Even in looking at those who have been affected by suicide directly or as families, and looking at even the forensic psychiatric system, because I've worked with Mathare Maximum Security Unit, where we have who we call psychiatric offenders who've committed heinous crimes, looking at how that system is broken and, making recommendations. But I think my highlight was, I think what I've done most is distribute surveys, because people are like, Charity talks on TV, she has patients. So most people want to channel researches through me, but these are just examples of different stages that I've been involved in for. So we did a quick survey for the sake of this presentation, and so we had 32 people who filled in. 5 were caregivers, 27 are persons with lived experience. Caregivers also have lived experience of caregiving, but that's how we've separated it. 88% had been reported had been involved in research. I must say, because it was a quick one, the people that we reached out to, I must say, have more access, let me say, to mental health research. So if I was to take this to most of the people I know who would not be able to fill on such a short notice, then the number would not be 88, but it would be 88% not involved. And so they were able to rate their experiences in language, purpose, design, length. And so these are the varied conditions that we had. We also had other. Some filled in. We started with prefer not to say, because we appreciate that this is sensitive information. People do not have to share. And I know even within our support groups, about 90% of people have not disclosed their status beyond their nuclear families. And so even engaging in researches where they fear that their information would end up at their jobs or somewhere like that is a very big risk. In terms of development, filling research, just like I gave my example, this is how they were able to fill in the percentages. And like I said, majority of these people have more access to research. Rating of experience, most of the researches that people talked about were a bit global and small, and by probably established research organizations, I would think, or at least the ones I engaged. And so they were more refined researches, but I can tell you, especially for individual students, I have seen everything. And so I would say, in terms of language, I think because most researchers are probably guided, it would be good. Purpose, Design depends. I was giving Rosemary an example where we were given a research of 30 questions each, 3 sections. and I think they were offering, I think, 100 shillings per section, and people ended up not doing. And even at the end of it, I didn't understand what the purpose was. Dissemination, internet facilitation is a big one. Like, we even had to think through, even for this small survey, how do we at least try to compensate the facilitation that people have used? Length of questionnaire. I mean, you're better at looking at these graphs than I am. So in terms of participation guidelines, I did see some questions as the other speakers were speaking in terms of where is this money going to come from, and these are very valid questions. As the NCD Alliance, and this is the Non-Communicable Disease Alliance, we came up with a global charter, and this was also with WHO, and we came up with sort of guidelines or ways in which you can look at how to have us participate. So we have guidelines for government, international partners, CSOs, research and academia, private sector. So I just pasted for research because they are also the least. So it talks of engaging us as active participants from design, to implementation, to M&D, strengthening community-based participatory research, research capacity. And decision making. So being involved from beginning to end. I have another slide from Welcome that is a bit more detailed, but I've put this link here, and it's also in the references. You can look into, you as a CSO, what it is you can do, and even for those who are asking, where will this money come from? We do need even big organizations like yourself, or like APHRC, to partner with smaller organizations and look for funds to be able to then facilitate persons with lived experience. I know it's not everyone who, you will write to and they run for it, but, in working with civil society, part of the community health workers can be, peer support persons like ourselves. So it can be through community health workers, through research, and so on. So there are many ways to go about it. In terms of gaps and opportunities, we are saying that in organization culture, policy, processes, lived experience should be there. I think Basic Needs is really trying on this one to have the culture going beyond, the storytelling, to actually having people like us involved in the processes in short-term and long-term projects, and even looking towards, meaningful engagement in terms of 5 years and so on. And so we need to build those cultures. And for a lot of you, because you also work with smaller organizations in research, when you begin to do this, you will influence other people in the 35 countries that you're working with and in the partners that you have. That within the policy is that the persons who are most affected by this are included. Formalizing opportunities by putting it in your policies, in governance, in decision making. And we have a slide where I will show how WHO has recommended for member states to do. Inclusion rights, like having it in policy and legislation. So like I said, being able to push for rights. We used, and I think Edwin was my biggest supporter in this one, in claiming the WHO rights and saying that we are not included in these tables, according or as endorsed by the WHO and Ministry of Health Quality Rights for Mental Health, or the UN Convention, which has been ratified in our country and adopted in our Disability Act. But also, yes, this we will never say enough. Design, strategy, planning, implementation, M&D throughout the process. Addressing power balances, I think Rosemary has covered this, simple, accessible formats. Because sometimes you leave us out in the jargon. You may not have this, discriminative language or stigmatizing language. But when you too much jargon or you make things complicated to do, then, we have those inequalities, because then we have people who are illiterate. And by the way, and even when most researches are online, it leaves out a lot of people, because when I think of my fellow patients at Madari, they are left out of a lot of these, activities in strategy, in research. So I'm very happy that even the one we are doing with the University College of London has focused on county community health facilities in Lebanon and in Kenya at the very low level. And so that then becomes accessible. And I remember there's one we were doing for pregnant adolescents who have suicidal and self-harm tendencies. And we had to translate, not only into Swahili, but the sheng of the different places. So the sheng of Kangemi is different from Kariobangi, but we made it as accessible as possible. And that required redoing, some research processes. And then clearly defining involvement. We need to agree in advance. What is the purpose of my involvement? What are my responsibilities? What are the expectations? Are you able to build trust and accountability? Because you see, Edwin and I are sharing experience that we've earned over the last 5 years. But I can tell you, a lot of that time has not been paid, And so it means, even as you're asking, where do we get this money? We have put in our resources into teaching you, but we are uncompensated for it. And that has happened for me, even at the UN, at the WHO, at the African Union, at Africa CDC. It's crazy. It's absolutely crazy that I'm still doing this. So in terms of do's and don'ts, Welcome have a very good strategy. They are your partners, so you've probably seen this, but they talk about doing. I just copy-pasted it. I didn't want to water it down. So ensuring we are involved throughout the process, preliminary and full applications, which I think is what I was also talking about, even redoing the processes, recognizing our value. Yeah, the value that we bring as professionals, but even in that lived experience, the value that we bring that can be used from the research place. And you see, as researchers, you have so much influence because everyone is looking to you to guide on how they would be able to funds. You are the evidence-based people. So when you provide this evidence and you say, as part of it, this evidence has also been collected by persons with lived experience who need to be involved in the projects that CSOs are doing, you have a lot of influence on that. Yes, multiple communities, contexts, mental health in Garissa and Kilifi are very different. Compensating, that one I probably cannot raise it better than Edwin has. It is important to pay. And I think the more we normalize it in our policies, the more even for donors and other people, they will begin to normalize this. And there's a lot of push on lived experience pay, not only for mental health, but for the LGBTQ community, commercial sex workers, the homeless, persons living with HIV and other many others. So this is a movement that is growing, and the issue of lived experience is quite needs attention. Acknowledging our contribution with even putting our names on these papers. I can tell you there's a very prestigious document that I've been named in, but no word I said is on that document, and that shouldn't happen. The don'ts are treating us as participants, rather than as experts or as partners throughout the process. Engaging us only for our stories. Like for me, my interest in advocacy and policy was not to share my story. It was to do policy. And sometimes I even prefer other people sharing their stories and I talk about policy. So there's a lot of, not empathy, what do we call this one? Entitlement. There's a lot of entitlement of people to our stories, yet they are ours. And we choose how to say them and to use them. And even if we do have to, then they need to be respected and treated right. In terms of the personal information that we share, our journeys and so on. Asking us to do small things that are not quantifiable, or being too rigid in involvement because we can contribute in many ways. Gaps and opportunities. Oh, sorry, I think those two slides came in between. So constituencies, like I was saying, even in the user caregiver, if it is mental health, we called people with bipolar, schizophrenia, like all across, and even the persons affected by dementia, the young, the old, people from counties, Kiambu County, Kilifi County, just having a wide range of people coming in, even for caregivers to be across, and even for media, we encourage them to get people from different backgrounds and experiences, because the experience of someone who has been treated by a traditional healer, treated in quotes, is very different from the one who's been treated by a spiritual healer, for example. Acknowledge our diverse experiences, perspectives, appropriate training through capacity building, person-centered language. So there are a lot of persons with lived experience who are very sensitive about the language used. I think I am guilty of, saying patients and caregivers when I'm speaking, especially to medics. But, there are people who prefer person with lived experience with bipolar or person living with bipolar, or, so it's easier to just ask someone, what is the name that dignifies you? Sustained community engagement, and this has to do with funding. And so what I'm saying is, in your proposals, even as you're writing out, include that as part of the community that will be engaged are persons with lived experience, researchers. And so we are looking to, and we already come to the table disadvantaged, because there are more people who are poor, who are affected. Poverty, is a cause and effect of mental health conditions. And so by virtue of the illness itself, when we are coming to the table, we are less financially stable. By virtue of having to afford using a lot of money in treatment, it puts us as a disadvantage. So consider that even as you have different people on the table in offering logistical and financial support that recognizes values and is accessible. So this is what I had mentioned, that the WHO in the framework, because the WHO guides governments. And so the guidelines they've given for themselves is what they have recommended for governments. So the first column is on remuneration. So this is what WHO should be doing, and we are really pushing them. And so 100% at the paying lived experience at the same level with experts, providing funding for sustained engagement, and that means including it in the project design and to the end, and funding relevant activities. And this means, sometimes even the best case scenario that we see. I think for the 50 meetings I've been to, I've only been facilitated probably for 10 of them, and that is for transport. And I'm giving my example not because I'm asking for myself, but where I am the best case scenario, many others have gone through a lot worse. Capacity building on the right of the screen is, the training that we need. Even the research-based and evidence-based work that you have that can then support us to be able to do our work better, where we're able to say, yes, for mental health, 0.01% of the health budget. You giving us those statistics helps. Guidance and practice, collection, use of data, reform guidance. I'm just checking in case okay. And then establishing global and regional training, and this goes across from advocacy to policy and other processes as well. So in terms of Africa, because this is gold because there's a silver and there's bronze, the link is in the references. But in terms of Africa, we are lacking on research and evidence-based, contextualized, well-documented case studies of the best case scenario of lived experience, involvement, remuneration, capacity building. Because when you bring us, 50 of us on the table, and you get to see how much we lack that capacity building, or how much we've had to struggle even without being facilitated for transport, then being able to provide even a best case scenario of Edwin, for example, and showing that it has worked and showing examples from basic needs and others, then it would help other, because people, we tend to copy paste what we see. And so once it is done and documented well, then, and in videos and all that, then it would be easier for, the different sectors to take it up in Africa. Guidelines, policies, frameworks. In terms of policies, like I said, yes, in terms of inclusion, yes, it's disability, but we do have global frameworks, which I think Rosemary went through. But since the task force, every other policy that has been there promotes lived experience, and you can use that to justify in your research. And so we are calling upon you, as a very influential research organization with a lot of influence on smaller research organizations, on civil society, to help us document and to give evidence-based, and to start with yourselves. to start with yourself so that people are able to learn from you. So I think that's what I have for today. I'm happy to answer any questions that we have. But I'd just like to finish with saying nothing for us without us. No strategy for us without us, no implementation for us without us, no design for us without us, no implementation with us for us without us, no budget for us without us, and no monitoring and evaluation for us without us. Thank you.
Thank you very much, Rosemary, for the wonderful presentation, and also Charity, as well as Edwin. So I will read some of the questions that we have received, and maybe you can address them. Okay, so the first question goes to is on how do you balance not causing more harm on an individual with mental health disorder and meaningfully engaging them? So how you engage the person with lived experiences with mental health disorder and not harming the individual.
I think let me try to answer that.
Yes.
I think from the onset is how you have designed, your project, and how you have designed the whole process from start to finish, and the part about the meaningful engagement, or how you intend to work with lived experience experts in your research, because mental health is on a continuum. So today, when I joined the research team, today I'm good. Today my mental health is on the up and up. But maybe 6 months down the line, I get some challenges, and it could be related to that, or it could be other issues outside the work, the research work, so to speak. So in such an instance, this is where we were talking about promoting well-being. What have you put in place such that if I get challenges during the process, do I have time off? Do I have, do you have like support system? Do you have some resources in terms of even just materials to for me to go through and realize that maybe it's this work I'm doing, maybe I should take a break? How have you designed the whole process? Because you might not know when I will get, and I think Charity can also agree with this, for conditions like bipolar, it's not when, it's not if I'll get an episode, it is when. So right now I'm good, but definitely sometime along the line, whether it is 6 months, 1 year, 5 years, I will have an episode. So that does not mean that you cannot engage me. It means that if I am in that project, and if I'm working with you, it should be designed in such a way that I can be able to maneuver, or I can be able to still access, health, and I still can be able to access services, not even through you, but even by letting the team know that I'll be off. I need some time off, or I need that. That is one way you can be able to promote the well-being of the people working with you, of the lived experience expert working with you. And if it is even much, if you are able to maybe even having a support system within the research team, or where people can be able to declutter after maybe a week of work, or after a few months, such things. But it has to be designed from the onset, not that when I have had an episode, that is when, or when I have had some challenges, that is when we are realizing that, wow, or we should have done this, or we should have done this. Yeah.
Thank you very much for that. And there is also another question that is almost relatable to what you have answered, which is how would you define equity and equality in the mental health space?
Maybe I could give a remark even as Charity or Edwin. Or Edwin, sorry, you can go ahead.
No, I think I was actually expecting Charity.
Okay, I think the first thing would be to recognize the unequal space that we live in when it comes to different inequalities. So, for example, whether it's gender or it is somebody, a woman with a mental health condition could have various levels of inequalities and iniquities. So they start from that base. So are your programs gender inclusive, socially inclusive, whether it's for disabilities, for gender and all that? And then recognizing the additional layer. And when you have the practice of addressing inequalities and iniquities, it becomes embedded because you are deliberate in finding out what are the barriers to inclusion. And I think Edwin went through quite a few and how to overcome that. So for example, if I am a woman with a mental health condition and you put for me a meeting at 8 a.m., I am a mother with school-going children, umeweka mkutano, I'm supposed to be there at 8 a.m. At what point am I preparing my children to go to school? Maybe it's especially in a rural setting. Make sure the cows are milked and the milk taken to wherever it needs to go and all. You need to be recognized. What are the duties this person is supposed to do? On top of that, what Edwin and Charity to do. Make me more
I think we lost you, Rosemary, for the last bit.
later in the day, or if I'm too exhausted, very noisy place that does not accommodate me. So it's because each one has a unique experience. We understand for a meeting, you cannot have a meeting, at least have that consultation beforehand. I'm sorry, Jill, I think I dropped off as I was responding to the question and I had asked Charity if she had any other views. My apologies.
Okay, thank you. Charity?
Thank you, Rosemary. I think you covered it well. So probably I can take another question.
Okay, Charity. So there is a question that is asking maybe basically who a person with lived experience expert is. So the question is, should the individual with lived experience be expert, professional, or any individual with lived experience, including patient, in good quality of life despite having the illness?
Okay, I'm glad it has been asked because there's a slide I had removed. I'm trying to go back to it quickly. That was talking about different roles and titles that people can have. And it does sound confusing, and I've been told this before, where you know, probably Edwin and I seem very, you know, well versed in matters lived experience, and we've had our exposure and our trainings and so on. And how I would want to respond to that is that there are various roles that people can have, even within the organization. You have the research assistant, you have the research strategist, you have the, I don't know whether you have graphic people who just deal with graphs. And so that's the way I would look at it. For example, when we are designing a program, say even for basic needs, basic rights, then I and Edwin are very key, or would be very key in coming up with, you know, what is this called? In analyzing and coming up with a strategy, for example, for a year or 3 years or 5 years, where then the persons with lived experience who may not necessarily be, you know, there's experts by experience, by virtue of the experience that I have been through, but there's also expert in terms of lived experience. So what I would say is at the senior level, or at the high level, or at the, you know, strategy level, or coordinator, where it is from strategy to M&D, then you can work with experts who then look at which lived experience persons can run the program, you know, going with the forms to Mathare or Kibera, I mean, the interviewees, which lived experience persons are able to handle, you know, or to do good interviews in a certain place. So I would want to divide it like that, where the lived experience expert in terms of managing persons with lived experience can be at that senior level, and then the day-to-day, yeah, or even in policy. Because I really appreciated the fact that I have been working with many patients, because there are questions I would be asked, and before, based on my experience, I would have said, yes, it's possible. But now, looking at 50 different people with different ages, socioeconomic status, etc., I would not answer it in the same way. So I would say that by virtue of lived experience, we are experts in our own right. And so I am an expert in the medication that I take and how it has worked for me and other people that it has worked for. But I am also an expert in terms of pushing policy and designing programs for lived experience. So I would say for the day-to-day, then we can work with lived experience persons. And if there's no expert, you can still work with those that are there. One thing I encourage people within our support groups, and because I also believe advocacy is part of the journey of recovery. Many of us, you know, first want to know, what is this thing? Is it real? Is it really scientific? Is just something that Dr. Tutai is advocating for? Then I get to the place where I want to meet people like myself. And then I meet people in Britain whose problems are losing games. And I want to meet someone in Kiambu, you know, and then I get to that place where I'm like, okay, I could not, I mean, I was affected by a drug. My kidney was affected by a drug after only 3 months of use, and I cannot change that. But I can help to push for better medication for other people. And so this is to say we all have value to offer, even me from my own experience, both as a caregiver and as a person with lived experience. But at the level of looking at the whole project, then an expert would be helpful. And we are not the only ones, Edwin and I mean, there are other people who are really also trying, and with different organizations. You may have heard, I've talked more probably from the NCD Alliance and WHO. He's had a lot more experience from GPA, those many alphabets, and also basic needs and other places. And there are places that we've been that are structured and can help us to help you structure what you want to do. But there are people who, and I have also been through that, and I'm sure Edwin as well, places where we've had to figure out on our own. So I'd say, let us sit together in a panel, yeah, of both experts and just persons with their own experience, and say, this level, these people are best to do this level, and also to look at, as Edwin had talked about, the experiences that we have. Like I said, my training is in community health and development. I've also done a lot of trainings, and I can add value in terms of training. So when you think it through from beginning to end, then it becomes easier to place each person with lived experience, where they will best be of service. Yeah, thank you.
I just want
Thank
to
you
add
very much.
something.
Yes, Edwin, go ahead.
Yeah, I think I do agree with Charity, and I also think that the minute when we are looking at mental health, when we are talking about lived experience, the basic is, do you have that lived experience of any mental health condition? At that level, that's the basic, that you have struggled with anxiety. You are an expert in that field because you know how anxiety feels better than any other person who doesn't. The interesting thing with lived experience and it's important to note this, that if we want lived experience to have impact in the world out there, it means that for you to be a very good lived experience expert, or to be an expert by experience, for you to be very good, at a certain point, you will have to step out of your own lived experience and look at other people's lived experience. Precisely what Charity and I have been doing for some time. Because I'm not the only one who has bipolar. I'm not the only one who is a recovered alcoholic. And I'm not the only one who has attempted suicide yet. There are so many other people. If I'm able to step out of that experience, my own experience, and look at Charity's experience and see, okay, this is what we can do. Maybe these policies can be able to work in this way, because I have started now collating and interacting with people and looking at having a different perspective from what I have always known. Now, that is where we make a difference. That is where lived experience in general will make the impact that we want to see in the long run. Because I'm not in my own shell saying me, as if I'm the only one with that condition. But I have stepped out. I am looking at other people. And that is where you see when Charity has gone to the extent of even talking about caregivers, because my wife, who doesn't have bipolar, she's a caregiver to me, so she has experiences. Yes, so in her own way, she has her own lived experiences of supporting his husband. So that is another angle, and that is another thing that we need to look at. That for lived experience to have the impact, the individuals now, Charity and I, and the rest of us, we have to step out and interact with other people so that we are able to do something about it. And that is another thing that, and I just want to highlight, like, for example, professionally, I am an accountant by profession. And I had to leave my job and now start a new job, a whole career change. But one thing that has been very key and very core to me is that at my workplace, my former workplace, I faced a lot of stigma, and it was not like intentional or calculated, but because I was a bit exposed, I could see the undertones of stigma and workplace mental health. So I I am at a place where I can say, when it comes to workplace mental health, I think I can call myself an expert in terms of understanding the stigma and the challenges that are associated with working in a workplace where there's a lot of stigma. So along the way, we pick a lot of things. So I have already stepped out of my own experience of just having bipolar, but looking at it, other people in the workplaces, how are they doing? And that is how I got to even got to go to work with Welcome Trust in that regard. So I think what Charity has said is important. It's very important, but we also now need to look at it from that perspective. Thank you.
Okay, I'm not sure if the moderator has gone off, but I've seen there's a question that has been asked thrice. by Mercy Mora, both in the Q&A and the chat. And the question is, in terms of inclusion, how do we effectively engage with lived experiences who've not received formal diagnosis? In our context, many individuals exhibit symptoms indicative of certain mental health conditions or disorders, yet they may not have undergone formal assessment and diagnosis. Consequently, we often inadvertently exclude them from our efforts. That is very true. And even before you go to those who do not have a diagnosis, one of the things I do with persons with lived experience in public facilities is to challenge them to go and ask their doctor, what is the name of my illness? Because the diagnosis is there, it's in the file. Sometimes because doctors will struggle with literacy with some patients and then assume that others also cannot, you find many patients will say, mi nakunyonga ile dawa ya blue, ile tunakatanga nusu, but they don't even know the name of the drug. Especially when it is first generation drugs, zile zinachotangwa kama njugu. And so then you have people like that who are being treated and they don't know what their diagnosis is. And diagnosis is not constant. Yeah. I think in my experience, diagnosis is dependent on the information that you provide. And the typical Kenyan family, and my focus is on public. I always want to give preference to public. You know, someone will be coming in, there are 50 patients waiting to be seen. And then the question is, ni nini umewaleta leo? Ni nini amefanya? And so naturally you talk about the last thing that this person did or the biggest thing they've ever done. Yeah. So if they've walked naked, that becomes the issue that has brought people to the hospital, and the diagnosis becomes about walking naked, forgetting that the radio, the non-existent radio this person was hearing 3 years ago, or saying that the phone is being tracked by the government, or questionable generosity, which we go through as persons with bipolar, and there are many who don't realize that that is a symptom. And so that means that if this person is just treated on the basis of ametoa nguo na anafuatwa, then it's likely to be schizophrenia. But when they come and probably that those symptoms have been dealt with, and now they are talking of now the other unsorted issues, you know, other symptoms, then you find that the diagnosis will change. And you will find the more someone gives information, and that's what I encourage people, give as much information as possible to get a proper diagnosis early. So this is to say that we have people who are diagnosed and they don't know their diagnosis. We have people who have been diagnosed and their diagnosis will change. There are people who, I've told you I have bipolar today. Edwin will tell you I have ADHD from his assessment. But at the end of the day, I think the person who calls the shots is the donor on this one. Because for you, you may decide that, no, I'll work with mental neurological substance use. So yes, I will include epilepsy. Yes, I will include neurology. But if the donor you're working with is very strict on saying, no, it's psychosocial disabilities, and for us, psychosocial 1, 2, and 3, they tend to determine who you're going to work with. And we are very touchy. As persons with lived experience, as caregivers, we're very touchy, or carers, we're very touchy on names. So you find someone with epilepsy saying, no, us, we are not mental. No. And others will say, yes, we are, because we need that funding. And that's why I was even saying it's just easier to ask someone, how do you wish to identify yourself? There has been an increasing trend of information online on acknowledging self-diagnosis, which for me, I think is a bit dangerous. But, you know, there's a movement that is, you know, anti-psychiatry. And that says, if you wake up and you feel, when you look at WebMD, you see you have ADHD, you are ADHD. And so I would say on these issues, it depends on the partner that you're working with. However, it is that they call the things that they call themselves and their descriptions is usually what you will end up working with. And that varies even for abroad, the illnesses and the diagnosis vary. And there are those who will acknowledge that those who feel they have an illness and do not want to be treated should be included in the research. I hope that is helpful.
And Charity, I just wanted to share briefly, thank you very much. I think you really covered that question well. I wanted to share briefly the experience of basic needs, working in a rural community in Kilifi, where we have champions with mental health conditions who are dispelling stigma in their community. And you're right, Marcy, many of them do not have a formal diagnosis. So when we do a call out for those who want to share their experience, that's all we say. It's people who have a lived experience, and we talk about mental health conditions, and we say it's when you're not well, when you're having challenges coping with your everyday life. We talk about the WHO definition. So we say, don't come and say, I have depression if you do not have a diagnosis of depression. But you can say, I have had challenges with my mental health, and you share that experience and how people's reaction, how a negative reaction affected you. Maybe some don't want to go for care because they don't want to be labeled. They don't want to be seen accessing those services because it comes with a label. And we describe how that's such a barrier to help. So it depends on, if you're being very specific, you want people with people who have a diagnosis of anxiety or depression, then as Charity has said, self-diagnosis can be dangerous. But if you're just generally you'll forgive me, but I think I had about finished what I was going to say. If you're generally working with people who have a lived experience of a mental health condition without relying on the diagnosis, don't leave out the rural communities or people who don't have the courage yet to go and seek services, because it does take courage in our setting sometimes. People fear the labels and everything. If you're generally talking to people who have had a challenge with their mental health condition, it doesn't limit you to at least it hasn't limited us in our experience at Basic Needs to people with a formal diagnosis.
Thank you very much, Charity and Rosemary. I don't know, I don't see any raised hand. Is there someone who has a question? You can raise your hand and I can allow you to speak.
Someone called John Black has raised his hand. Joe.
Okay. Sorry, Fred, could you, I think the Zoom when
John
I dropped,
Black, go ahead and ask your question.
Yes.
Okay. Seems like he's disappeared from us again.
I think there's one question in the chat.
Okay, yeah, there is a question, and also, so from Gandhi. So it's a comment and a question also. So I was about to speak about, I was about to ask about neurodiversity. How do we navigate this? Because as a folk with this, we are not seen as a person with significant mental health condition.
Let me take that if I may. That's a very good question, and I identify as a person with who is neurodiverse because I have severe combined ADHD, and just like I think Charity has rightly put it, when it comes to the issue of self-diagnosis, especially with a condition like ADHD, and with the advent of even TikTok, because TikTok has been very notorious. Everybody I meet is identifying as as a person who has a lived experience of ADHD. And sometimes I feel it takes away, the person who really struggles with ADHD, like me, who has to be on medication and therapy, a person who has to be on medication every day. If I didn't have medication, having this, meeting would be a challenge. So navigating this is a challenge. We have to say it as it is. And when we look at even things like the neurodiverse conditions, we go the whole spectrum. We look at autism, we look at dyslexia, dyscalculia, all those conditions. And I think it just has to be on our part. We have to continue advocating, and I think we have been advocating for mental health as a whole, and the conversation has started, gaining traction. But I think now we need to also now start looking at individual, some of these conditions which are not picked and which might be taken as not as serious, because if I was to share a bit of my experience, if my diagnosis for ADHD had been I had gotten that diagnosis when I was young, chances are high I wouldn't have ended up in full blown addiction. But I was diagnosed when I was an adult. I was diagnosed when I was 30, and with ADHD, for example, you will see that as a boy or as a young boy, you will be seen as unruly and naughty, and you know what happens in society. You will get hooked. So I think we need now to take that initiative and start talking about these conditions and letting people know what they really mean. What being neurodiverse means. And I think now people are only looking at neurodiversity as ADHD, but they are not looking at things like autism. They are not looking at things like dyslexia. All these are neurodiverse conditions that you will find people struggling with. And we need to put our voice out there. Just like one of my slides, was putting across, the voices of people with lived experience are the ones who are going to carry the day. And if Charity and I and people like us have not been doing this for quite some time, we wouldn't even be having these meetings. So it has taken some work and some effort to bring out whatever we are doing even today. So it is upon us, the people in the neurodiverse community, and other people who support who would support us, to come in and start engaging and looking for ways that we can bring this conversation, such that when you tell a person that you have ADHD, or you have a lived experience of ADHD, they won't tell you that you are over 30 and you have a family and kids. How can you have a condition that is for kids? Because some of these things are also stemming out from lack of information, ignorance, stigma, and it's upon us and other people in this movement to talk about and to bring out the pertinent issues in such forums and work through that.
Hello, can I speak?
Well,
I see that now I've been allowed to.
Yes.
oh,
Great. So thanks for very nice, comprehensive webinar. My name is John Black Kabuche. I am a medical doctor from Uganda, so across the border. But I'm also a researcher in digital health, and my work in mental health has involved setting up a hospital telephone service where people call in and receive general information about mental illnesses. How that relates to lived experience is that we co-created this service in terms of the design, the setup, the content, which messages should be sent out with patients and caregivers and peer support workers, so patients who are recovering, who are better. Even more interesting is that some of the people who answer the calls, the call agents, when a person makes a call, some of the people who answer calls are actually patients who share their lived experience with others, and that actually has been the highlight of the service. People call in and they've asked things like, "You mean you are mad yourself?" And the agents say, "Yes, I am." So they know the language that is used that is stigmatizing, but they have come to terms with it, and they want to use that to leave the caller in their way and say, yes, I am, I'm not mad. I had a mental illness. I am now much better. And so you should also come in, or you should bring your relative in. And that actually makes a very big difference. However, one of the things that has come up that I realize that makes it a bit difficult to engage, and I'm a very big advocate of engaging patients, not just in mental illnesses, but also in cancer care and everything else, is the issue is that, when someone is a patient, they are at a disadvantage already. And as someone mentioned in this webinar, there's a power difference between a doctor and a patient. It is even worse when the patient has a mental illness because there's a stigma. And so the question that I have is, should we treat patients as special? So in terms of seeing, yes, they need something extra. They need to be given different assistance. I think there was a word that I liked from the presentation, something like reasonable compromise or reasonable accommodation. Because usually when you say reasonable accommodation, you are asking for them to be treated differently, to be treated as a special case. And yet, on the other side, that seems like when you treat them as a special case, it also promotes them being stigmatized and being separated from the rest. So my struggle here is, how do we balance this? So being to reasonably accommodate them, which might mean that, for example, they can't do the same amount of work as others who don't have the illness because of the fact that they have an illness. But if you then acknowledge that, you are now promoting the fact of looking at them as others or as separate, as different from us. So I want to hear on how we balance this. How do we balance reasonable accommodation, which promotes them being seen as different, versus we trying to include, patients, be it mental illness, be it cancer, be it whatever, to not look at them as they are different. They are the same as us, and therefore we should not treat them separate. I hope you get my question.
Yes, let me respond to that. Reasonable accommodations, as I had tried, as I had explained, or rather I should maybe go deeper a bit, is I don't think reasonable accommodations are there so that they can differentiate that Edwin is different and is not as good as Charity and he will need A, B, C, and D. That is not what reasonable accommodations are. Reasonable accommodations basically are noting the differences that people have in different areas. And when we are looking at mental health conditions, when we talk of reasonable accommodations, it is not a tool to promote differences or to play favorites. These take for example, putting a ramp instead of putting a ramp and putting a staircase. Having both in your workplace. That is one form of reasonable accommodations for a person who has a physical, disability. You are not playing favorites. You are trying to make that person, or you are trying to support that person to access the same services that a person who can basically use the stairs go to get the same access. So in terms of reasonable accommodations, it is providing an equal opportunity for that person who is having challenges. And having challenges doesn't mean that you are different or you are special, because even in a person who doesn't have a psychosocial disability or a physical disability, we are very different as human beings. So it doesn't mean that because me and you are very different that you are being treated special. But now when you come to look at people with psychosocial disabilities and people with physical disabilities, definitely when you put a ramp in your office so that a person with a wheelchair can get access to you, just like a person who doesn't have a physical disability can get access, you are basically making it a level playing field so that I can come and see you at your office comfortably, and the other person can come and see you at your office comfortably. You have basically leveled the playing field. You are not playing favorites. You are basically actually it's a way of having meaningful and meaningful engagement with people you are dealing with, or with the groups that you're dealing with. Yet, I hope I have explained it, well, and I think also Charity can add some weight on that.
Okay, thank you. I think that's well spoken. And by the way, this is not a concern that would come just from another organization. Even I myself, in fact, let me give an example. When I was speaking at the World Health Assembly in Germany in September, during that time, I had been in depression, functional depression. My memory issues had really increased. So I was so worried about how I'll get to the hotel, how I'll get to the room where I'm supposed to speak. And so I asked my hosts to, help me with someone to go see the room in advance. And on the day that I am speaking, that I get to be there. And so I had to sort of balance within myself where to ask for help and where to just help myself. Because I also have to create a balance between not being an inconvenience to people versus having reasonable accommodations, which are basically to say we with invisible disabilities, the same way that National Council provides a support person to work with the blind or visually impaired, or to, translate for someone with audio disabilities, is the same way that probably I need that flexibility. Like at Basic Needs, there's a short-term project that we are doing, and I requested to come in at 10 a.m. because I told them the medication I take sort of clears in my mind at 10. And even all these media stations that have shows at 6 in the morning. In fact, the last media station I went in the morning, I did such a bad job because my mind is not on point. And so it is a balance that we need to achieve. And I think the best way, so in Germany, I ended up getting to the hotel 3 hours later because I didn't even have fare to get to or cab money to get to the hotel. I didn't have internet. I couldn't access. They don't use Google. They use some other, place platform. And even, and so there was that balance of, there are times I'm getting lost, but since I'm not the one speaking, even if I get lost and come 15 minutes late, it's okay. No one has died, so it's a balance that we need to achieve. So last year, again, it's around the same time, September, I was living an NGO office and I got lost, literally. Like my memory was so bad. I had burns, and so I got lost. And I really struggled. I looked at all the people I know in the organization and I really felt I have already asked for 10 a.m. I have already asked, and so I don't want to then call and say I'm lost and people tomorrow are wondering whether I've made my way to get there. And so I thought that if we have that, if we have an in-between person, and this is probably what I was preempting when I was saying having an expert and then having the rest, where I am able to speak to this lived experience expert and say, this is a challenge that I am having in getting to this place by 10. This is a challenge I'm having in getting lost. And so that the things that I ask from an organization are two, but two, I'm able to get support from this support person or from a psychologist. So especially with organizations that are large and you're dealing, or maybe you have a research project that has 13 people with lived experience, at least there can be that leader who then comes in between to say, okay, these are the support systems we will ask from you. That will not be too much to ask per se. And this is the support that we can provide for ourselves within the lived experience team. But it's also to say that it is it's very easy to glorify mental illness, even as we push for, these accommodations and so on. And I want to go back to the previous question that was on neurodiversity, because I was a board member of a government school for children with special needs, and we couldn't call it intellectual disabilities. It had to be special needs. And we had the challenge of, for most with disabilities, assessments are done in government facilities. They are done by the physiotherapist, who probably is not as well versed as the occupational therapist. And so you would find out of our 50 children, 40 come with the education assessment, because there's the hospital assessment, there's the education assessment, and then there's also now KISE, the Kenya Institute of Special Education. And so the district or the sub-county assessment, 40 of our children would come with mental challenges, because autism had to be very clear, because we have a ratio of teachers 1 to 4 children, but all others is 1 teacher to 10 children. So you find even this diagnosis, because you see someone in the village will not know that this is an education assessor, this is a physiotherapist, and so they may have 3 cards written different things. So you'd find when we engage Kenya Autism Trust, because for them, they are older, their kids are 30s, 40s, they understood autism as a communication disorder. If you go and try and say it's neurodiverse, you'll be beaten. And if you go to Dream Autism Trust, where many of the founders, their children have both autism and seizures, for example, then they look at it as neurodiversity. But I think we do need to find that balance between not glorifying or making, mental illnesses be sexy, and also not looking like there's nothing we can do for ourselves. So it's a balance that both of us need to reach. Thank you.
Thank you very much, Charity. Priska, you can go ahead. Priska Usero.
Hello, thank you for this opportunity. My name is Priska Uselu, and I am an aspiring global health expert in child and maternal health in low and middle income countries. So my question is, how can we approach mental health cases where, for instance, in a village, somebody is living with a mental disorder, for example, schizophrenia, but then the amount of stigma in that community has led to a situation where they are labeled mad or crazy, and they are not included in anything that goes on in the community. So even them, they shy away from seeking help or from accessing any form of medical attention or even social care that is provided by people who assist care for them. So it becomes a bit difficult for their loved ones to even be there for them, because they have become hostile, and they feel hated, and they feel extremely discriminated, and it's hard to watch their lives deteriorate, and it just becomes difficult. So how can people deal with things like this? For instance, for their loved ones within the family, what are some of the ways that maybe the family can try and help them, or even the community as a whole? Like, are there some programs that will come about to tackle such issues? Because this is a case where the person knows that they have this kind of mental disorder, and their family is willing to assist, but the kind of attention that the society gives it makes them feel like they are rejected even within the family where they are loved. So how can somebody go about such a case? Thank you.
I think what I'm hearing is basically stigma, and stigma is one of the biggest challenges that the mental health the mental health movement has been facing for decades. So in as in as much as it's very hard, one of the things that has always, worked or needs to start happening is a lot of, psychoeducation from the community level, moving forward, because the family is willing to help, but the person who is struggling with the condition already has self-stigma. And then we have the society at large that looks at that family in a different way. And the reason why this is happening is, they stigma, they understand, mental health in a very different and negative perspective. So there is the angle of having, the community perspective, understanding and appreciating mental health. And being a person who was involved in the Time to Change global project with basic needs, after some months or after some time being engaged in the project, research findings found out that people had started changing their perspective after seeing what we were doing in the community, talking about our challenges with the mental health, and that we can thrive when we have, despite having mental health conditions. So we have, in this case, or in this scenario, you have the community to think about, starting to, provide information about mental health and ways in which people can understand and appreciate mental health. That is one. Number two, we are looking at this family and we need to also psychoeducate them further and psychoeducate the person who has the mental health condition, so that they will move from self-stigmatizing themselves. All of us, and I think I speak even for Charity, at some point, even at this level of awareness, at times you will find us self-stigmatizing ourselves. So it is a journey. It is not a one-stop, stop shop that you will fix everything. It is a journey that will have to be continuous. You'll have to understand the community, the language, the kind of, support systems they have, and how they can be used to, destigmatize and educate members in the community. It is that involving, but it has to start somewhere. You have recognized there's a problem. Now we go into looking at what interventions can you run, because that is one way to start changing that community. And I always say this when it comes to stigma. When I keep quiet, stigma wins, and I can't let that happen. So even for you in your individual circles, do not keep quiet in the face of stigma, because you keep quiet, you will have challenges. And you have also said something that I also resonate with very much, that that particular family or that particular person is not willing to even go and access help, despite knowing that they have a mental health condition and maybe there's some kind of intervention that can. Why? Because stigma decreases access to care. That's another fact. So I think